because they just immediately go back. I have had pretty bad side effects with the hypertension portion of it. I do like it for sedation or intubation if they need to be continued in sedation. But other than that, I do prefer Versed to not. Sorry.
You use it?
I like it for all the reasons she hates it.
No.
I think it's great, especially like with pediatric, like ortho injuries.
Mhm.
You can just give it intranasal instead of fighting that 4-year-old to get a line.
Yep.
We don't have it in a nasal.
I've never used it, because we didn't carry it in Orange County. They were just getting it when I was retiring, but, yeah, I go through fentanyl nasally. But we also didn't have any sedation for it or whatever protocol. None. Like, really?
Not our initial sedation, it's for continued sedation.
It's for contagious. You guys will do versatile-tominate, and if they're coming out of it,
You
you'll
can do it.
snowball with some ketamine.
Yeah.
You guys do ketamine knock them out?
It sucks.
That sucks.
Recording.
Your other one is glucagon, also known as glucagen, right? It is a hyperglycemic agent. It's going to make blood sugar go up, okay? It is also a pancreatic hormone. Exact same hormone that your pancreas produces in which cells? Islets of Langerhans, the alpha, the beta, or the delta cells. I remember from back in P1? Probably not, because
P1's a blur.
we haven't talked about endocrine. It's actually from the alpha cells. So what glucagon will do, or glucagen will do, is glucagen or glucagon goes to the liver and breaks down the stored sugar in the liver and releases that back into the bloodstream. Okay. It also gets the liver to make new sugar, gluconeogenesis, make new sugars. So glycogenolysis, breakdown of glycogen, the stored sugar, or gluconeogenesis, it does both. Okay. It also has a little positive inotropic and chronotropic effects. Inotrope meaning it's going to make the heart beat a little stronger, and chronotrope means it's going to make it beat a little faster. A little, not a lot, very little. It slows down GI motility and secretions, and you'll probably see it used in the hospital more for that than you will for anything else. Right? We're not worried about GI motility for us. Indications for us. Altered LOC when we're suspecting low blood sugar, and I could not give them sugar. So why can I not give them sugar?
You can't get the light?
Well, they're either confused so much they can't orally have sugar, or I can't get the IV or an IO. Then we would go to glucagon, right, or glucagen. So if I can get an IV or IO, that is preferred. In fact, they do not carry glucagon in this county. Glucagon is probably the most expensive drug that you will have in your drug box if you have it. Yeah. So the IO needles you guys carry with your drill are $118 each. Add to it the tubing, the lock, the securing device. Add to it the D10 or the D50 or whatever, the drip set to run all that in. You're probably at $150 to give somebody that IO. Still cheaper than glucagon. Yeah, it is a super expensive drug. That and amiodarone are the two most expensive drugs. So a lot of places will not carry it for that reason, because if I can't get the IV, I'll just get a IO. But if you do carry it, we will only give it IM for low blood sugar. Why? I can give it IV.
You can get IV and you just get dextrose.
If I have an IV, I'm just going to give dextrose, right? It's also used as a partial antidote for symptomatic bradycardia in beta blocker and calcium channel blocker overdoses. Okay, I'm telling you, you don't have enough. The dose for those was like 3 to 10 milligrams. You may have 1 milligram on your truck. I worked in Orange County. We had to carry 10 milligrams of glucagon. Yeah, we had $1,280 of glucagon on the truck on 52 apparatus. We administered 1 dose for low sugar in 5 years. We had 1 beta blocker overdose call in 5 years. Yeah. Guess how much they carry now? Goose egg. It's too expensive. Contraindications, they're allergic to it, they've got pheochromocytoma. What does that do again? Those adrenal tumors, dark colored adrenal tumors. Problem is they will push blood pressure way up. Obviously hyperglycemia, and then insulinoma, an insulin tumor. Side effects, dizziness, headaches, low blood pressure, tachycardia, nausea, vomiting, rebound hypoglycemia. All right, and I'll explain that in just a second. So this person's sugar is low. We're gonna give this hormone, it's gonna pull any residual sugar out of their liver, right? Get their sugar up. Well, as soon as they burn that sugar, what happens? It goes down and now they have absolutely no reserves. So if you ever have to give glucagon for low sugar and you wake them up, you need to follow that up with getting them to have some sugar. Great, we got you awake again. Eat a sandwich, have a candy bar, drink a Coke, something to start replacing that sugar. Okay? Just use all their reserves. Interactions, it's incapable with most, or insoluble with most other drugs. So it gets its own IV if you're giving it beta blockers. It's also why we go IM with it. Dose, 1 milligram for low sugar. IM or nasal. They can go nasally. Okay. Repeat dose until symptoms have resolved. You know, calcium channel blocker, they're saying 5 up to 10. It used to be 3 to 10, so now it's 5 to 10. Pediatric, over 20 kilograms. 20 kilograms is a 5-year-old kid. 1 milligram. So 5-year-old, we're giving the adult dose. Under that, you're getting a 0.5 milligram. Onset within a minute, peak effect 5 to 20, duration 60 to 90. Pregnancy category B is very safe. Not recommended for use in lactated women. Ineffective if they have no glycogen stores. Who would not have glycogen stores? Who would not have stored sugar in their liver?
B. Boy.
Dialysis.
B, I was like.
No, not necessarily
B, what was
diabetics,
it?
but
Dialysis.
not dialysis.
Malnourished.
Malnourished,
Luna said it.
right? People who are malnourished, they don't have a whole lot of sugar, and then I'll throw one other one in there. Usually you're chronic alcoholics, because they also end up being very malnourished. So don't expect it to work really well.
What about a patient who got glucagon within the last 2 to 3 weeks? The storage takes anywhere from like.
Oh, to replace it,
An endocrinologist told us 1 to 6 months. We had a patient that we couldn't get lines on, we were giving glucagon weekly. And it wasn't working after like the second time, and that's what was explained to us.
I've seen at Orlando Health, if glucagon was given, even though this patient's awake and I'm fine now, they're like, nope, you're getting an IV and we're giving you an amp of D50 or a bag of D10 or something, trying to get some of that sugar back into their liver for storage. So yes, it fixed it, but you burned all their reserves. So, you know, think of whatever, you're flying in a plane and boop, the low fuel light comes on, you go like, oh, put the reserve tank over. Okay, now what? When you run out, you're out. You have no reserves. So that's what you got. So you get those quizzes.